Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week it's a conversation about the use of radiation therapy with Dr. Joseph Contessa. Dr. Contessa is a professor of therapeutic radiology and of pharmacology at the Yale School of Medicine. Here's Dr. Weiner.
So, I like to start off just asking people about themselves, and tell us a little bit about how you got interested in radiation oncology, a little bit about your background, maybe even before radiation oncology.
So I was a neuroscience major in college, and I came out and I worked in a laboratory and progressed on to actually have the opportunity to work in a radiation oncology focused laboratory. And I had this love of neuroscience, but there was really some, I thought, great opportunities for getting involved with cancer research. It was and still is very exciting because we do cure patients, and there's just this great opportunity to improve the therapy to really have better benefits for our patients and better clinical outcomes. So I started at the Medical College of Virginia, went on and trained at the University of Michigan, and I've been at Yale now for 15 years.
And you are, as we call people like you, a physician scientist. You have both a MD and you have a PhD, and you combine laboratory research with clinical research and clinical care.
Yes, and that's really one of the exciting parts of what I get to do. I get to work with patients, on a weekly basis, daily basis, and address problems in the clinic. And then I get to take some of those insights and go back to the laboratory and ask new questions and try to develop, new strategies or new answers to help us think about new ways of treating patients and, to make some progress.
So how long have we been using radiation to treat cancer?
Oh, my goodness. We've been doing this probably for 100 years now. And in fact, the first cure in oncology came from the treatment of lymphoma, Hodgkin's disease with radiation therapy. And
I remember that when I was very early in my career, when I was probably still a resident, I saw radiation oncologists mark up a chest X-ray, and they would draw all these lines on the chest X-ray, trying to draw lines around the tumor, and then essentially would point the beam in that direction. Is that a fantasy, or am I remembering this right?
You are remembering this exactly correct. And I think I came into the field just on the back end of that time. And so at that time, you could think about treating it almost like you had a flashlight, right? You would shine the flashlight in a certain direction, and that flashlight would be the radiation. And the technology has progressed, just as we've seen technology progress, right, in every field. The technology in radiation oncology has progressed to such a great degree. So to use that, kind of analogy of the flashlight, so then we moved on to almost, if you can imagine, laser beams. Instead of just one flashlight, laser beams coming out of the flashlight. And then that was probably about 10 years ago. And now what we've moved on to is, if you can imagine that instead of those being laser beams coming out, they're almost like strobe lights. So you have almost 100 strobe lights, and we're shining that flashlight, and we're moving that flashlight during treatment. So we get very precise delivery of radiation.
Well, it really has come a long way. But has the fundamental way in which radiation kills cancer cells changed as a result of that?
So it's allowed us to give higher doses per fraction. That causes different mechanisms.
And if I can just interrupt,
sure.
For our listeners, a fraction is one dose of radiation. So in a typical course, there could be one fraction occasionally, or there could be as many as 30, correct?
Correct. And what this new technology has enabled is for us to give higher doses of radiation per fraction because we can be more precise. And that causes some additional forms of DNA damage and cell death. And I think so that's one answer to your question. The other is that what we've realized is that adding additional therapies on top of radiation can also be beneficial. So the most, I think, exciting therapy over the past 10 years has been immunotherapy. And what we've discovered is that radiation in some situations can prime an immune response and so enhance some of the effectiveness. And so that's, for example, been seen in lung cancer, where you treat with radiation and you follow with an immunotherapy and you get a very pronounced response.
And so just to go into that a little more, is that because the radiation is actually killing cancer cells and the products of that process are somehow enhancing the immunotherapy?
So this is an kind of very exciting for research. And I don't want to get too technical here. Maybe we'll just go back to kind of high school biology for a second. The main way that cells die after radiation is through mitosis. And mitosis is when cells divide. So after you radiate a cell, it doesn't always know that it's dead. It waits until it divides in order to die. And when it does die in that way, it can expose DNA and it can activate certain pathways, which then can also stimulate the immune system. So this is an area that, there's a lot of research going on right now.
So essentially the cell isn't quite dead yet. It actually divides and it is unable to effectively divide. Is
correct? Yes, that's where we talk about, again, clonogenic death. So if the cell can't divide and keep renewing itself, it's effectively dead.
Got it. And what cancers is radiation used for? Or maybe I should actually ask the reverse question, which is what cancers is radiation not used for?
Right. So as you're alluding to, radiation is used for many different disease sites, from brain to head and neck cancers to breast cancer to GI tumors, to lymphomas that we mentioned, to cervical cancer. It's been thought that there are some tumors that are radio resistant, meaning that they have characteristics that they don't respond to radiation. However, I think what we're seeing right now is that by delivering higher doses of radiation with more precision, we may be able to impact and improve care. I think the tumors that we still may not have a big role in is when diseases have progressed a significant amount and it's difficult to control the extent of disease. But that's still an area of active research.
And there are times when medical or systemic therapy is given to treat all sites of cancer in a person's body, and there's still a need for some localized therapy with radiation.
Yes, absolutely. And I think this is an area where, we need more research. The overall goal is to try to control the more bulky areas of disease with radiation. Again, we can point that flashlight at a specific area, but what we're not good at is trying to point that flashlight over the entire body, because that would cause too many side effects.
And sometimes radiation is used to cure patients, and sometimes radiation is used to help symptoms, even in settings when we may not be able to cure people, but we try to help them live longer and live better.
Absolutely. And one other area to note is that radiation can also be used for sparing or preservation of tissue. The great example is the larynx, the larynx or the voice box. When you have a tumor of the voice box, you could just surgically remove it, but then you would lose ability to speak. You would lose ability to swallow. And when you treat the area with radiation, you can preserve the anatomy. And so it may not offer a better curative effect than surgery alone, but it does offer the ability to preserve the organ.
So you were talking before about the ways you can give higher doses of radiation to more localized areas by some of your planning techniques and by advanced imaging. What are the advantages from a side effect standpoint of doing that? And what are the side effects that you see with radiation? Not that they're all the same.
Yeah. So I think the best way to answer that question is to focus in on something specific. And because I treat brain tumors, I'll talk about them. When tumors spread to the brain, so when patients develop brain metastases, it's important to treat because unlike other sites of the body, if they continue to grow, they can cause significant side effects. You can think about, these types of side effects, headaches, nausea, vomiting, seizures. So we treat them.
And the problem with the head is that it's a pretty small place.
Yeah, it is a pretty small place.
And that when cancer grows, there's not a lot of your head can't expand.
Right. It's important real estate.
Yes.
And so we want to treat these areas, but we want to spare as much of the normal brain tissue from radiation as we can, as well as to reduce dose to other organs or nerves that might be more sensitive to radiation. And so, for example, there are techniques or machines that are available that really have pinpoint delivery of radiation. One of them is the gamma knife. The gamma knife enables delivery of high dose of radiation to a specific area. And I gave the idea of a flashlight before. The gamma knife works a little bit differently. Here, there are 200, you think about 200 lasers coming from different directions and pinpointing on just one site. And so we can get very high dose to that one site of metastasis, not a lot of dose of radiation to the brain, and we can effectively control that region.
And that one site could be a couple of millimeters even.
Correct. The accuracy.
Or it could be bigger.
It could be several centimeters, or it could be just a few millimeters. The accuracy of a gamma knife is less than a millimeter.
And so the side effects of radiation to the brain, though, are going to be very different than what you see when you give radiation to someone's tumor that may be in their abdominal cavity.
Right. For CNS, thankfully, for approaches like the gamma knife, it's really low impact. Patients, kind of walk out and they feel a little groggy within a day or two. They're back to normal. For other tumors that are, I think, different types, like gliomas or meningiomas, which we also frequently treat, there the side effects are typically local. So we usually talk about hair loss, skin irritation. If we have to give chemotherapy concurrently, we talk about some fatigue. And those side effects typically hang around for a couple weeks after radiation, but then usually get much better.
Well, we're going to need to take a break for just a minute, and we'll be back with Joe Contessa, professor of radiation oncology and pharmacology, and we'll talk to you in just a minute.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Gastrointestinal Cancers is committed to detecting pancreatic cancer early and using state-of-the-art technology to treat the condition. Learn more at smilowcancerhospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone, there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting even after decades of use can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as the Battle II trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening. This is Eric Weiner again. I'm the director of the Yale Cancer Center, and I'm here tonight for Yale Cancer Answers with our guest, Dr. Joseph Contessa, professor of therapeutic radiology and pharmacology at Yale School of Medicine. We've been having a conversation about radiation oncology techniques and treatments, specifically related to brain tumors, and we're going to continue along this path. So, Joe, we've talked about how radiation is much more precise than it used to be. Where's it going in the future in terms of precision? I think there are new machines that are being developed that help us better both image the tumor so we can treat it more effectively with radiation, and maybe give us information about areas of the tumor that are more or less active.
Right. There's a lot of explosion of technology in this area. We've talked about it a little bit. One of the areas that has progressed is trying to use PET scans, so a radioactive label that will detect the tumor, and to use those radio tracers to identify the tumor during treatment. So there's new linear accelerators based upon this. One is called the reflection. And there's a lot of enthusiasm in the field for trying to advance this type of treatment to increase precision. There's also a lot of enthusiasm about delivery of proton therapy. This is another type of radiation that has been limited to just a few sites in the country. And it's again, something that it's a type of therapy that, based upon the physics of delivery of the protons, could have reduced radiation doses to normal tissues and have a benefit there.
And we're going to have a proton facility in Connecticut in just a couple of years, which is a collaboration between a number of different institutions. And that's going to be located where? Just north of New Haven. And I think, Eric, you point out it is going to be a collaboration. And this is really important because it's something that, Connecticut's not a big state, and we don't actually need, 4 or 5 proton centers that cost $40 or $50 million to build. We need to do this collaboratively and work together in order to, achieve our goal, which is to deliver better care for the patients who need that specialized therapy. Yeah, no, I think it's really critical. And until now, people who have needed to receive proton therapy have gone to either Boston or New York, and there really won't be a need for that for any patient in Connecticut come a couple of years from now. And proton therapy is particularly helpful for kids with cancer. And many of those children over the past few years have been going out of state. Absolutely.
I think we all look forward to getting that unit and that site online and being able to provide that care.
So it sounds as though with some of the new techniques to give radiation, we're able to do two things. And it's not often that these go together, but in this case they do. And that is achieve fewer side effects and more effective anti-cancer therapy. It's exactly where we want to be going in both areas.
I agree 100%. And if I might add, one of the biggest different changes, I think, over the past 10 years in radiation oncology has almost been a philosophical change. So as we increase our ability to be more precise, it's also changed how we think about the treatment of tumors. So we used to think about, well, we're just going to treat a tumor locally. And you can, think about if a surgeon treated a tumor locally and excised it, radiation can do that. We would think about radiation as a regional treatment, so just beyond what could be, surgically removed, because as we know, cancer frequently has microscopic disease that spreads into tissues. So radiation was very good for that. But now we're really thinking about, with this precision and reduced side effects of incorporating radiation into the treatment of distant disease as well. And I think that's been a real step forward.
One of the points that we've made previously here on the show is that cancer therapy is very much a team sport, for lack of a better term, and that it takes a number of different subspecialists coming together, working very closely together to take optimal care of the patient, who is actually also very much a member of that team. In fact, probably the most important member of that team. And so who do you end up working with when you're planning treatment?
Yes, this is absolutely a team sport. And that's why it's also such a pleasure to work in a group like we work with, where we have members from different teams, and we have the opportunity to really specialize and get to know what all of those members do and they bring to the table. So to give you an example, for brain tumors, we work very closely with our neurosurgeons, with our neuro-oncologists, with our pathologists, with our radiologists, with our experts in nuclear medicine. We have, I think, other medical professionals that play a huge role, our nursing staff, our PAs, our staff that are inpatient and outpatient. And then in radiation oncology, we have a team of physicists, which help us with planning and ensuring the accuracy of the machines. We have a team of radiation therapists who help to deliver the treatment every day. And we have teams of dosimetrists as well who help with all of the planning. It really is a very large endeavor in order to make sure that we are delivering precise radiation therapy on a daily basis to improve care for our patients.
Can you talk a little bit about your own research and how your research fits in with what you see day to day in terms of taking care of patients?
Sure. You might have to stop me if I go on too long.
So it's okay. This is your life's work.
Well, when, as I mentioned before, when you see patients, day to day, and a lot of patients you can really help, but there's always some patients you can't. So having that extra outlet of going back to the lab to ask some questions is very fulfilling, and hopefully will bring, new ideas back to the clinic. And so when we think about how can we improve radiation therapy on the beyond technology, on the biological side, we think about how can we enhance the initiation and lack of repair for DNA damage, which is what leads to cells dying after radiation. We think about the signals that cells receive in order for them to survive radiation, growth factor signaling, for example. So blockade of growth factor signaling can enhance radiation therapy. We study that in the lab. That is something that earlier in my career I studied quite intensely and has actually translated to the clinic in head and neck cancers, where we use an antibody to a growth factor receptor in head and neck cancer to improve the efficacy of radiation. I mentioned mitosis and cell division. We're currently studying ways in the laboratory to make sure that cells just don't take a pause after radiation so that they can avoid that mechanism of cell death. And we're also interested in, cells can also put up these signals after, chemotherapy or radiation therapy, these signals on their cell surface that say, don't eat me, to the immune system or to other cells which remove dead and dying cells. And so we're interested in how can we disrupt those signals as well to try to improve therapy.
And does this work apply across the board to different types of cancer? Does it specifically apply to a limited number of cancers?
I think that's really been an exciting finding, is that different cells use different types of mechanisms. And you would think that something like radiation, which should affect cells, every cell the same way, actually does not. And so that's something where we've been able to use genetic screening to try to now dissect those different mechanisms and identify them. So there might be one mechanism that's specific for a head and neck cancer, and another mechanism that's different for a lung cancer, and another mechanism that's different for a brain tumor.
Well, and on some level, this is what makes different cancers respond to different therapies, and why the prognosis of some cancers is so much more dire than others. You work in an area that is brain tumors, where our progress over the last couple of decades has been less than in some areas. What do you see in terms of the future for what I'll call primary brain tumors, or the tumors that start in the brain and stay in the brain, as opposed to metastatic cancer, which spreads to the brain? But for primary brain tumors, where are we going?
Yeah, it's a big challenge. It's a mountain to climb. And I think we're beyond the base camp, but we're still climbing. That's for sure. And that's why I think we need more research in this area. There have been some advances just in the past few years. One is the development of a small molecule inhibitor, a drug that targets a specific mutation in low-grade gliomas. That mutation is called IDH. And that has been shown that this new drug can slow the growth of those tumors. That's pretty exciting. We now have a way to identify tumors that will respond to a drug. And we haven't had that before with brain tumors. I think that from the radiation oncology perspective, there's a lot of excitement about minimizing the fields of radiation and being more precise in order to get better control and balance the side effects versus the efficacy. But I think there's other directions that are emerging. So one is to increase the delivery of drugs to the brain. I think, we have something called the blood-brain barrier that prevents drugs from getting in. And it's very important. It protects us from poisons that we might encounter. But we need to figure out how to deliver drugs better. And that's an area of ongoing research.
Dr. Joseph Contessa is a professor of therapeutic radiology and of pharmacology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.